respected faculties, especially Dr. Khalid Mohsin sir. Today's talk, different talk. I think it is related. Evaluation of breathlessness and fatigue. We are very much grateful to you to kind of consent regarding two topics. Thank you, sir. Welcome you to this session. And Dr. Professor Jalaluddin sir, Arun Maske, and other faculties, we start to this session. Thank you all. Professor Wadud sir.
Assalamu alaikum and good afternoon, everybody. I hope everybody will be enjoying today's session. This is a very important thing. After the chest pain, this breathlessness and fatigue, these are the most common complaints that cardiac patients and also non-cardiac patients present to us. And we have to evaluate whether this is due to cardiac cause or non-cardiac cause. How do we approach to that? Is it related to something very sinister or something much less sinister? Only gentle reassurance will be enough. All these things we need to evaluate. And Professor Khalid Mohsin is the best person. He is a teacher and he likes to teach. And as my direct teacher, I pay respect to him. And we are really happy that today he'll be giving the lecture on this topic. Thank you, sir. Sir, you can start.
Thank you, Wadud, for your Sorry, I have been screen share. Okay. I have been having some problem with the screen sharing. Sorry.
Sir, kindly minimize the screen of your browser, sir.
Okay. Okay.
Minimize it, then you will find your desktop, sir.
Yeah. Okay. Okay.
Okay,
Thank you.
Okay, sir.
Thank you,
Excellent.
Professor
Yes, sir.
Wadud and Dr. Mohsin for the kind introduction. This is the second time I am with you. The first time I was here with heart disease in pregnancy. And as you all know, Dr. Wadud has very rightly pointed out that the evaluation of breathlessness and fatigue is very important from a clinical point of view. And this is one of the 4 cardinal symptoms of heart disease as well as some non-cardiac disease. You have already enjoyed the lecture of Professor Chowdhury Meshkat Ahmed on syncope last Tuesday, and our respected Dr. Mominuzzaman sir will be speaking on chest pain, and Professor Atahar Ali will be speaking on palpitation, which will cover the whole spectrum. So let's start. Shortness of breath, as we all know, it affects about 25% patients attending the ambulatory care. This is the outpatient departments. It is an unselected patient population. And some cases of shortness of breath are of potentially life-threatening consequences like pulmonary embolism, pulmonary edema. It has some relation with some comorbid conditions like COPD, chronic kidney disease, and maybe suggestive of the diseases like heart failure with reduced and preserved ejection fraction. And this symptom, if it is related to organic disease, it's a predictor of increased mortality. How we define breathlessness? According to American Society, Thoracic Society, it is a subjective experience of breathing discomfort, which is a qualitatively distinct sensation that vary in intensity, deriving from various factors, which include physiological, psychological, social, and environmental factors. The subjective experience include effortful respiration, a feeling of choking, asphyxiation, and air hunger. Let's look at the epidemiology of the shortness of breath and fatigue. I will predominantly focus on shortness of breath because fatigue is almost are of similar background, and the investigation modalities are also quite similar. About the 7.4% patients presenting to the emergency rooms come with dyspnea. In general practice, those who attend, about 10% of the patient, they complain of shortness of breath when they walk on a flat surface, and 25% when they walk uphill or when they climb stairs. Dyspnea is about present in about 5% patients who in the persons who are consulting a physician. And in cardiology practice, it is quite quite significant number of patients, about 15 to 50% patients, they complain of dyspnea. And in pulmonological practice, the percentage is even higher, about 60% of the patients. And in the acute settings, about 12% of the patients who are attended by the emergency medical teams, which are not available in our country. This is the paramedics traveling over ambulance. About 12% of the patients have very grave shortness of breath, and about half of them needs to be hospitalized, and the mortality in hospital mortality is quite significant, to be about around 10%. This is just a recapitulation of what I have told before. The rescue service, those who are paramedics arriving in the ambulance, emergency room, the patients who are attending the emergency. Here we can see the COPD is a very important cause. It is of course is the European data, about 17%, the heart failure 16%, pneumonia about 9%, myocardial infarction, cardiac arrhythmia, malignancy, pulmonary embolism. This is also the percentage is relatively small, but many of the patients of pulmonary embolism remains undetected, and these are very difficult diagnosis. And in general practice, the epidemiology is a bit changed. Here the respiratory infections, asthma, COPD, they also predominate, as well as the heart failure. How we classify breathlessness or shortness of breath? These are the three broad classifications according to the timing. There may be acute onset, there may be intermittent, and there may be episodic. And the chronic ones. The chronic ones, when the symptoms are persistent for more than 4 weeks, there may be acute and chronic presentation as well. And there may be some background of the symptoms. There may be symptoms at rest, symptoms on exertion, symptoms triggered by emotional stress, and the change in body position, exposure to allergens, and so many other things. And there is a etiopathogenic classification, the respiratory system related symptoms, where the control of breathing, airways, and gas exchange are affected by the pathological process. The cardiovascular causes, the mixed causes, we must keep in mind that a lot of patients, they have dual causes, cardiac and pulmonary. Though these two are dominant, but they frequently coexist. And there are some other medical causes which we also need to evaluate, because these causes are sometimes overlooked, like anemia, thyroid disease, physical debility, and also a lot of patients, they suffer from shortness of breath due to psychological causes, mainly the female patients. In a lot of patients in our practice, we find the husbands are dwelling abroad for a long time, and they are sometimes presenting with sometimes very functional type of symptoms. Then the functional status in a patient with shortness of breath, we are very much aware of the NYHA classification. Just for a recapitulation, the NYHA class 1, there is organic disease definitely present in the cardiac or in the respiratory system, but the patient don't suffer from any symptoms on ordinary physical activity. NYHA class 2, they suffer from shortness of breath on ordinary activity with slight limitation of their activity. NYHA class 3, they are suffering at a less than ordinary activity. This compromises their quality of life, and the NYHA class 4, they are breathless at rest. So we frequently encounter the NYHA class 3 and 4 patients in our practice, mainly in the outpatient and in the inpatient services. So how do we work up a patient of shortness of breath? Whenever a patient comes, we need to take a detailed history. We make a thorough physical examination, but due to our high patient load, these two are sometimes neglected. So we must not forget about these two things and jump to the third tier. But if we neglect these two things, we may lead to doing a lot of unnecessary investigations, which might be financially causing a lot of burden to the patients in our socioeconomic condition. The diagnostic evaluations are important, but we need to choose them very judiciously, which include complete blood count, these are the biochemical tests, natriuretic peptide, D-dimer, cardiac enzymes, arterial blood gas, renal function, thyroid function. ECG is a very important tool. It is cheap and easily available. It may give us a clue to the underlying ischemia, arrhythmia, pulmonary hypertension. Echocardiogram is very much available in all parts of the country, and it should be included in a evaluation of patient with shortness of breath. X-ray chest PA view is also very important. It gives clue to both pulmonary and cardiac symptoms, but it is not diagnostic of cardiac etiology, but for pulmonary etiology like pulmonary congestion, pneumothorax, pneumonia, interstitial lung disease, it is very much informative. Ultrasonography of chest, there is a renewed interest in this technology in the COVID-19 era, and it is also traditionally been used to detect small peripleural effusions. Pulmonary function test, though it is very difficult for some patients to perform and interpret, but it is also has got an important role. These three parameters are important from a cardiac point of view. Natriuretic peptide, PNP and NT-PNP, these are the two common ones. I will discuss them later. The cutoff value of PNP is less than 35 and NT-proBNP less than 125. This has got a very good negative predictive value. Troponin is a very commonly preferred investigation, and we must keep in mind that the troponin can be elevated due to some non-coronary and non-cardiac causes as well. The troponin I or T, and positive predictive value of troponin is not 100%. And D-dimer, again, it is also very much caught the attention in the COVID era, and it is a fibrillation. It is found at a higher detectable level after a thrombotic event. It is also has got a high negative predictive value. The positive predictive value is not that good. It almost rules out the thromboembolic pulmonary thromboembolism as a cause of pulmonary embolism, and the positive, if we cannot rule out, then the other investigations they come into play, like, and these are supplemented by the imaging study, and we assess the risk scores by the Wells criteria or the Geneva criteria. Then according to acute onset shortness of breath, I have already mentioned that it is a potentially life-threatening condition, and most of the patients, they require hospital admission. And in hospital admission, they are sometimes need to be admitted in an intensive care unit or a high dependency unit. So we need to select those patients who need a proper admission and proper evaluation. And there are few red flag signs or alarm signs. These are confusion, the new onset cyanosis, the patient is often unable to complete a sentence, the respiratory effort is inadequate, and the patient is almost exhausted. And in these patients, we need to monitor the vital parameters like heart rate, blood pressure, oxygen saturation, and these are scored by a system called the Apache scoring system. this is the acute acute factors, age, and chronic diseases are taken into consideration. There are 12 points, and the scoring starts from 0 to 71. And there are numerous revision, and presently the Apache 4 score is being used, and it is used in it predicts the outcome of patients in the intensive care units particularly. And then if we come to the systemic causes, among the cardiovascular causes, we are much more concerned with the congestive heart failure, because breathlessness is a cardinal symptom of congestive heart failure. It can also predict coronary heart disease, valvular heart disease, congenital heart disease, myocardial and pericardial disease. And among the respiratory causes, nowadays the COVID-19 infection is at the top of the agenda nowadays. It is a part of atypical pneumonia, and the other diseases which are predominantly evaluated include bronchial asthma, COPD, interstitial lung disease, obstructive sleep apnea. And as I already mentioned, there are some overlaps in many patients between the two systems. According to the miscellaneous causes, the psychological causes include anxiety and panic attack, somatization disorders. Anemia is very important in our population, particularly in female patients. And according to the criteria, the hemoglobin concentration in male, though it is very satisfactory in our country, if it is less than 13 gram in men and 12 gram in women, the patient is labeled as anemic according to WHO. And in many patients in our clinical practice, we have seen that the patients have ended up in having a coronary angiogram only because the anemia has not been properly evaluated. The symptoms like chest pain and fatigue has been caused by these symptoms. So we need to evaluate anemia, and in cardiac patients, we must correct the anemia, particularly in patients with ischemic heart disease. If the anemia, if the hemoglobin is less than 10 gram, it should be corrected on a very priority basis. And there are some upper airway condition which is dealt with by the ENT doctors, that the upper airway obstruction. And if the tidal volume is reduced by 30%, it definitely causes symptoms. The underlying etiology are maybe congenital malformation, infection, trauma, neoplasm, and foreign body as well. In case of young children, the foreign body impaction of the upper airway, it can give rise to shortness. The neuromuscular disorders, the various neuromuscular diseases like the Duchenne's atrophy, myasthenia, amyotrophic lateral sclerosis, Guillain-Barré syndrome, we must be very familiar about Guillain-Barré syndrome. That sometimes the ascending paralysis, sometimes the patient at many a time need the ventilatory support to save them from respiratory failure. And we must not forget about the iatrogenic causes. The beta blockers, particularly the non-selective beta blockers, and ticagrelor. Ticagrelor, we must keep in mind that ticagrelor can cause unexplained shortness of breath in about 14% of the patients. So we must keep this in mind. It is very important because we are using ticagrelor more and more nowadays, and it can cause shortness of breath. Actually, this is a table what we have. I have already said. If we start the head and neck region, on this side there are acute causes. On this side there are chronic causes. Angioedema, we must be very cautious about it because some AC inhibitors causes angioedema. There may be vocal cord edema as well, the foreign body, the pharyngitis, then diphtheria is another cause. Chronic cases we have time to evaluate, which I have already mentioned. The chest, there might be some rib fracture leading to flail chest. There may be some pneumothorax. There may be some pneumonia, pleural effusion, pulmonary embolism. The acute ones, we must evaluate the patient very meticulously because we don't have much time to evaluate the patient. So we have to be very precise in our initial assessment. And the chronic, there is a long list. We don't need to go into those. There is the cardiac causes. There are, sorry. The cardiac ones are the acute coronary syndrome, congestive heart failure. There may be cardiomyopathy, tachyarrhythmia-related heart failure, valvular heart disease, pericardial tamponade. And the chronic causes include chronic pericardial disease, pericardial effusion. There may be cardiac shunting. There may be some form of cardiomyopathy and valvular heart disease. There may be some metabolic causes, particularly leading to acidosis, like the diabetic ketoacidosis, the salicylate poisoning. The other cause of metabolic acidosis include chronic kidney disease. There may be some poisoning as well. And the neuromuscular cause I have already described. And there are some non-specific causes which include sepsis, fever, anemia, acute kidney injury, psychogenic hyperventilation. There may be some pregnancy patient, the pushing up of diaphragm by the gravid uterus sometimes cause shortness of breath. Here is a scenario of psychogenic shortness of breath. A lady who is suffering from claustrophobia, she is being evaluated by an MRI, and she is terrified on entering the tunnel of MRI, which is likely to cause more claustrophobia. But this sort of investigation should be avoided because this will cause, in many cases, it will be very difficult to complete the investigations. That the open MRI is a solution, but it's not available everywhere. And another thing is the obstructive sleep apnea. It is not to criticize the woman, but here the women don't shut up all day and the men don't shut up all night. The obstructive sleep apnea, which is very important to recognize that it is an important cause of refractory hypertension. Then it can cause premature coronary artery disease. It may lead to respiratory failure and pulmonary hypertension. These are the things we need to be very cautious. And the patient history is very much suggestive, and we need to refer the patient to the pulmonologist or the ENT specialist for a further workup. Congestive heart failure is the most important background etiology for shortness of breath. In association with shortness of breath, there are fatigue, effort intolerance, fluid retention, and there may be associated coronary artery disease, cardiomyopathy, hypertension, valvular heart disease. And the echo has can classify those patients in 3 broad categories: heart failure with reduced ejection fraction, where the ejection fraction is less than 40%, heart failure with preserved ejection fraction, where the ejection fraction is more than 50%, but there is an elevated cardiac filling pressure. I will come into further details, and there is a mid-range ejection fraction as well. What are the essential components for diagnosis of congestive heart failure? The symptoms and signs of congestion in the systemic and the pulmonary veins. There may be structural abnormalities in the heart. There is the evidence, echo evidence at least, of impaired ventricular filling. There is the exclusion of other symptoms. There is evidence of reduced exercise capacity and elevated natriuretic peptide. These are the very cardinal features of congestive heart failure. And these are the common symptoms: the dyspnea of different grades, effort intolerance, fatigue, ankle swelling, weight gain, nocturnal cough. It's also very important. And also paroxysmal nocturnal dyspnea. It is very important because the fluid is redistributed when we lie down at night, and the patient classically start to have their symptom about half an hour to 1 hour after lying in a flat position, and they tend to get up and they feel some respite, and they feel much better when they go to the windows or to the balcony to get some fresh air. And there is another symptom, like it is called the bendopenia, when the shortness of breath occurs when bending forwards. It is maybe in some people with a very pendulous abdomen, they have some mechanical problems like this when they bend forwards. Sorry. Regarding, there are some additional features we need to inquire in a patient, like the drugs which retains fluid, like NSAID, analgesic steroids, the infection. There many heart failures are triggered by infection. I have already mentioned about anemia. Infection include influenza and pneumonia. The dietary features also very important, like the salt and fluid intake. Their physical activity, the sexual activity. Many of the heart failures patient, they present late at night or early in the morning. It might be related to sexual activity. And there is peripheral edema, chest pain, anorexia and satiety may be due to congestion of the GI tract or the liver. There is the blood cannot go to the heart because the compliance is reduced. There may be weight gain, that is very important due to fluid accumulation. We need to measure the weight of the heart failure patient every day, or at least alternate day. The sleep apnea I have already mentioned. The palpitation, syncope. If the patient is on ICD, the ICD shocks are important. It may indicate fatal arrhythmia. The symptoms of TIA and thromboembolism, as because the risk factors are common in coronary artery disease and cerebrovascular disease, there might be some TIA or thromboembolism. And we need to check the number of hospitalization, because as the heart failure progresses, the hospitalization number and duration tends to increase, and it indicates a poor prognosis. And compliance to medication, it is also very important. We need to inquire with the patient as well as the attendant. And the vaccination, like pneumonia and influenza vaccination, they can protect the patient with repeated hospital admissions. What are the signs? We all know the jugular venous pressure, particularly the internal jugular vein. We should not evaluate the external jugular vein. The hepatojugular reflux, it is important when we suspect congestive heart failure, we don't get a very high jugular venous pressure. The third heart sound, it is very important, with or without gallop. The respiratory rate may be high. There may be heart rate high. There may be hepatomegaly due to congestion. There may be pleural effusion, predominantly right-sided pleural effusion. If you find the left-sided, we think about pulmonary pathology. The pedal edema, it disappears very fast on diuretic therapy, so we might not get it. The pulmonary edema, it is initially at the bases, and at the disease progresses, it may cover the whole lung fields on both sides. But we should, if we find a basal crepitation, we must ask the patient to cough. And if it disappears on cough, we think that this is due to pulmonary edema. If it remains the same, we must consider the interstitial lung disease or pneumonia. And sometimes it is asked in the examination why the crepitation of pulmonary edema disappears on cough. We all know the alveoli are interconnected by an orifice called pores of cone. And if on coughing, there is redistribution of the alveolar edema fluid, and it attenuates the sign. And we have to auscultate to find the valvular regurgitation. And fourth heart sound, it implies that the patient is having reduced compliance of the heart. These are some other things which if the patient needs further evaluation, we might measure the blood pressure in a standing position. We can do the Valsalva maneuver, which is helpful in hypertrophic cardiomyopathy. Then these are the right ventricular heave we might find in the presence of the obstructive lesion of the right side of the heart or pulmonary hypertension. And the temperature of lower extremities, the extremities may be cold in the patients with low cardiac output. If we find a patient with fatigue and with low BP, their temperature in the legs will be lower. And if they are taking beta blockers, if the beta blocker is non-vasodilatory, it will further reduce the temperature of the lower limbs, which might mimic peripheral vascular disease. Baseline investigation I have already mentioned. The iron profile, it is also very important in case of cardiac patient. It has been recommended by the guidelines that the transferrin saturation should be kept more than 20. So we calculate the transferrin saturation with the help of serum iron and total iron binding capacity. And the ferritin level also should be within normal limits. ECG, it's a very preliminary investigation, and in the most of the times it is normal, but we need to check for the STT changes, Q waves, which might suggest a coronary artery disease, and if there is atrial fibrillation, we need to anticoagulate the patient, and if the patient comes with significant bradycardia, high grade AV block, we need to consider pacemaker implantation. And ventricular tachyarrhythmia is a very grave condition. We need to evaluate, and in many cases, the LV function deteriorates after an episode of tachyarrhythmia, particularly if the atrial fibrillation is persistent for a long time. It might let us explore the possibility of a cardioversion to put the patient back to sinus rhythm to improve the congestive heart failure. The chest X-ray also, as I already said, that it is not that important in cardiac illness, but in pulmonary disease evaluation it is very important. The cardiac shadow will be enlarged in transverse diameter. There may be pulmonary congestion of different grades. I'll show you an ECG X-ray. There may be upper lobe diversion. There may be Khalid's line. There may be bat swing edema. It depends on the mean pressure, the LA pressure or pulmonary capillary wedge pressure. It is correlates with the pulmonary capillary wedge pressure. The presence of pleural effusion may be dominantly right-sided. The lung vascularity important. The LA may be enlarged. We can have an indirect evidence. The pulmonary artery may be enlarged. The peripheral artery and the central artery, we need to evaluate both of them. The Khalid's line, it implies the interstitial edema. Here we see the pulmonary edema. Dr. Monwar has graciously allowed me to use his slide. There is a bat swing opacity. There is upper lobe diversion, if we correlate with this sketch, and there is a Khalid's line, and there may be bilateral or right-sided pleural effusion. So we need to differentiate this finding from non-cardiogenic pulmonary. This is obviously cardiogenic pulmonary edema, but we need to differentiate from non-cardiogenic pulmonary edema. And this is also a slide of Dr. Monwar, and there may be the main thing is the factors include the heart size in non-cardiogenic pulmonary edema. It is usually normal. The shadow in pulmonary edema, there is central shadow, and in the ARDS there is peripheral shadow. Khalid's line are more common in case of cardiogenic pulmonary edema. Pleural effusion is also more common in cardiogenic pulmonary edema. And if we have an old film, we can compare. It can give a lot of information in evaluation and management. The echo parameters, we echo is almost a mandatory investigation. What are the things we need to see? The enlargement of cardiac chamber, the ejection fraction, I have already mentioned the 3 grades of ejection fraction, the diastolic dysfunction, valvular regurgitation, pulmonary pressure, the systolic pressure and the diastolic pressure. LA volume index, when the left atrial volume is the body is the ratio between the left atrial volume and the body surface area. The global longitudinal strain, it is in the specialized echo called speckle tracking, and it is not routinely performed. IVC diameter is very important. It includes, it gives us an idea about the compliance of the right side of the heart. The pericardial effusion and pleural effusion, pericardial effusion, it is the investigation of choice, can see, evaluate the pleural effusion as well. And there is, we can see some structural abnormalities like aneurysm, thrombus, etc. We need to evaluate the systolic function and the diastolic function. The grade 1, grade 2, grade 3. The diastolic function is very important. Systolic function, there is 3 tiers. If the ejection fraction is more than 55, we call it is a normal systolic function. It is 45 to 55 mild. It is 30 to 45 is moderate deterioration of ejection fraction. It is less than, this is severe LV systolic dysfunction. And grade 1, it is the EA ratio is less than 1, deceleration time more than 200 milliseconds, E by E prime less than 9. Grade 2 is a normalization pattern, EA ratio between 1 to 2, deceleration time 160 to 200 milliseconds, E by E prime 9 to 12. Grade 3, it is a restrictive pattern, EA ratio is more than 2, deceleration time is less than 160, E by E prime more than 12. And these are the heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction. Here the natriuretic peptide level is high, left atrial volume index is more than 34, and LV mass is also increased, E by E prime less than 9. And heart failure with preserved ejection fraction, LVF is more than 30. There is also rise of natriuretic peptide and left atrial mass compared to the body surface area, as well as LV mass index, and the E prime is more 13, and mean E is also increased. Professor Nazrul Islam has already described these parameters in his lecture in detail, so I won't go into much details. The biomarker is very important in evaluation of patients with congestive heart failure. They can rule out congestive heart failure, they can predict short-term and long-term prognosis, and they can give us an idea whether the anti-heart failure therapy is benefiting the patient. And if the patient is on ARNI, we should depend on NT-proBNP, not BNP. We should keep this in mind. And this already we know all this difference between reduced ejection fraction and preserved ejection fraction. There is here it is the systolic function is impaired, and here the diastolic function. The more men suffer from reduced ejection fraction, and contrary to the women, in reduced ejection the patients are relatively younger. Here the patient is more than, it is the older patient, because we know that the compliance of the heart decreases with age. Here the MI and the dilated cardiomyopathy predominate, and here the hypertensive heart disease, atrial fibrillation, valvular heart disease are more common. Here the LV is dilated, but here the LV is not dilated, but then has got concentric remodeling, and the end diastolic volume is not increased. And in those cases, in case of reduced ejection fraction, the vasodilators are the treatment of choice, but here the vasodilators are not of much benefit, but here the drugs which prolongs the diastole or modulates the diastole, have a beneficial effect. The myocardial injury here, it is more pronounced. We can evaluate them by various imaging study. And here there is no injury is not dominant, but inflammation and fibrosis is more prominent. And we must be aware of the the fallacy of measuring the biomarkers. We can get the higher levels in aged patient, in patient with renal insufficiency, RV dysfunction, atrial fibrillation, pulmonary hypertension, pulmonary embolism, anemia, sepsis, myocardial regurgitation. And the lower level, it is expected in obesity, the pulmonary edema, flash pulmonary edema. We all know that it can occur with renal artery stenosis in cases of pericarditis and in case of end-stage cardiomyopathy. There are some other investigations which might be useful but not routinely performed. It includes cardiac CT, cardiac MRI, PET scan, SPECT, catheterization including CAG, endomyocardial biopsy. Nowadays, endomyocardial biopsy is rarely performed. Coronary artery disease, they don't usually produce breathlessness, but when they produce, we call it angina equivalent. It is common in female, elderly, and diabetics. And these are the precipitation of breathlessness may be due to physical, mental stress. There may be cold climate, heavy meal. If there is such background is found, we may consider the shortness of breath to be angina equivalent. And if we cannot delineate the origin of the shortness of breath, the patient should be subjected to further imaging studies or stress studies. And if indicated, coronary angiogram can be performed. Valvular heart disease, we all know that they cause shortness of breath. The predominant is aortic stenosis and mitral valvular disease. Aortic stenosis, we have already attended the lecture. We all know that it causes exertional fatigue, exertional syncope, dizziness, chest pain. The second heart sound is usually soft. And if the valve is non-calcified, we can get an ejection click with an ejection systolic murmur relating to the carotid. The mitral valvular disease may be mitral stenosis or mitral regurgitation, but stenosis causes more shortness of breath. But acute mitral regurgitation can also can give rise to intractable shortness of breath because the LA has got little time to dilate and absorb the hemodynamic load. And the murmurs of mitral stenosis and regurgitation we can get by clinical examination. Then we just recapitulate a few causes of respiratory cause. It is a chronic inflammatory airway obstruction. There may be episodic shortness of breath, mainly nocturnal, may be triggered by some allergens like the respiratory irritation by fumes, gases, allergen, exercise, cold, infection, other things. Auscultation reveals vesicular breath sound with prolonged exhalation with or without bronchi. The spirometry reveals a reduced FEV1 and peak expiratory flow rate. But in between the episode, these are normal and there is a dramatic improvement after use of bronchodilator and some cases with anticholinergic drug. And there may be some acute exacerbations as well. Chronic obstructive pulmonary disease, it is a combination of chronic bronchitis and emphysema. As per WHO, it is when the cough and expectoration persists for at least 3 months, for at least 2 consecutive years. It is usually found in smokers and ex-smokers, and it is a fixed airway obstruction with destruction of lung parenchyma. And the FEV1 FBC index is low, and residual volume may be increased in emphysema, and the carbon monoxide diffusion is low, and chest X-ray reveals hyperinflated lungs. Pneumonia, this is very important in this COVID era. because it is a type of atypical pneumonia. It is the symptoms are breathlessness, pleuritic pain on deep inspiration or movement, fever, cough. There may be tachypnea, bronchial breath sound, coarse crepitation when particularly the pneumonia is resolving, and there may be some rise of inflammatory parameters. The microbiological evidence we can get in the sputum, blood, bronchoalveolar lavage, or pleural aspirate, and we can get the evidence in chest imaging like CT, X-ray, and the arterial blood gas can predict some complications. And we all know the curve 65 score by which the parameters are confusion, uremia, respiratory rate, blood pressure, and the age. And it classifies the severity. The patients with high score should be admitted to the hospital, particularly in a high dependency unit. This is one of the X-ray of the COVID-19 infection. It is the bilateral peripheral consolidation and bibasal ground glass opacity. We have to be very cautious because many of the COVID patients tend to come to the cardiologist. So we should screen them properly. And this is a CT scan. It is a peripheral ground glass opacity bilaterally. And there is also is a relatively uncommon pattern, the crazy paving pattern. Though we don't advise the CT scan always, but it is justified to do the CT scan. Interstitial lung disease is also a common cause of shortness of breath. The patient produces with non-productive cough. There may be end inspiratory crepitation. And the patient have cyanosis and clubbing. The female patients predominate. The pulmonary function test reveal low vital capacity and low total lung capacity. And there may be high FEV1 IVC ratio. And the carbon monoxide diffusion is impaired. The chest X-ray may reveal honeycomb lung, and CT chest, there are different pathological patterns which can, the CT chest give us an idea, and sometimes the lung biopsy is necessary, but usually not. These are some of the chest X-ray patterns. There is consolidation, there's a interstitial lung disease affecting the bases mainly. There is some the nodular, the miliary mottling in infection. There may be some secondaries. All can give rise to shortness of breath. Pulmonary embolism is also a very important cause of shortness of breath in the acute setting. There may be sudden death as well, and the patient have dyspnea of acute onset. There may be pleuritic chest pain if there is pulmonary infarction. There may be hemoptysis. There may be syncope or near syncope. And the examination, there may be reveals, maybe many of the symptoms and signs are non-specific. Tachycardia, tachypnea, hypotension, refractory hypoxia is very important. And we might get a thrombosis of the lower limb, but we should take care that we should not elicit the Homan sign. It may cause the thrombus to dislodge. And ECG may reveal S1, QT, T3 sign and precordial strain. These are not specific. There may be oligemic lung. There may be wedge-shaped consolidation with or without pleural effusion. Echo may reveal a thrombus in transit to the right side of the heart. The lung imaging, the CT pulmonary angiogram, or VQ scan. If the lung is clearly visible, then I think VQ scan is very good if there is no parenchymal pathology. But if there is parenchymal pathology, CTPA is the diagnostic modality of choice. And we can exclude the pleuritic type of chest pain as because the D dimer has got a very good negative predictive value. And recurrent thromboembolic pulmonary embolism can lead to pulmonary hypertension. This is called we classify as the type 5. This is a well score. We all know we can, when we suspect pulmonary embolism, we can use this score. This is the evaluation of chronic breathlessness. We start with history. We evaluate the vital sign. We do the relevant tests like the laboratory test, ECG, chest X-ray, pulmonary function test, AVC, then carbon dioxide diffusion. And if we suspect a pulmonary pathology, we go for the additional test. like the chest CT, VQ scan, then the bronchoscopy, pleural aspiration, and if we suspect the cardiac cases, then we go for cardiography first. Then if indicated, we can go for cardiac catheterization, including CAG. We can go for myocardial perfusion imaging. We can go for cardiac MRI. We all know that the lead gadolinium enhancement is a very good modality. So I think I have come to the end of my topic. Many of the things covered in this lecture has been discussed before. So thank you very much for your kind attention. And if you are awake, I thank you again. Thank you very much.
Thank you, sir. I think elaborate discussion, sir, because breathlessness fatigue is a big chapter, but you covered all the cardiovascular disease, I think so, in this lecture. Cardiovascular related breathlessness fatigue. Thank you, sir. Wadud, sir, few comments, sir. Then you go to the question answer.
One thing is that the Khalid has shown what a number of conditions can produce this sort of a presentation, breathlessness and fatigue. And the history is so important to decide which way to go, which investigation you should try. And that investigation should be coupled as first tier investigation, second tier investigation, so that we can use the logistics very reasonably without putting too much cost on the patient. And that's the important thing. If you know what to look for, you can actually find out the cause very rapidly at a very limited cost. That's the most important thing of these lectures, to let us become aware of all the things. Most of the things we know, but some of the things we forget. And that's the important thing. Thank you, sir. Thank you for putting all these things together in such a nice and elaborate way.
Thank you, sir. Before go to the panelist, I just a few questions put on the chat box. I did not question in the exam. A young female with 2 months amenorrhea comes with severe shortness of breath at midnight. What are the differential diagnosis? Young female, 2 months of amenorrhea, sudden severe shortness of breath at midnight.
Yes.
What are the differential diagnosis?
Actually, we have to evaluate the background of the patient first. Actually, it might be some cardiac illness, because the rheumatic heart disease, they manifest in the pregnancy first, but it is too early in the pregnancy, but it manifests a bit late in the pregnancy. And another diagnosis in pregnancy is very important, is the peripartum cardiomyopathy. It is also manifests a bit late. It is near the 3rd trimester. And in our country, many of the things we cannot, in the patients, the females particularly, they are anemic most of the time. Particularly, the anemia aggravates during pregnancy. But in this group of patients, we should consider the rheumatic heart disease as a first modality in our country. And there might be some pre-existing valvular disease which might have aggravated with due to the increased the circulatory volume. Though it increases in the 2nd trimester of pregnancy, but in the 1st trimester there might be some symptoms, and there might be in pregnancy also. It is also, patients are also prone to pulmonary embolism as well during pregnancy, and pulmonary embolism we should rule out in those cases, and the respiratory causes we should also keep in mind. We should not forget about the respiratory causes, and the other medical causes also we should keep it into consideration. And in pregnancy, I think the patient deserves more attention from the family, particularly here the 2 lives are concerned, and most of the time they go to the obstetricians first, but they have to refer the patient again to the internist or the cardiologist or the intensivist, and here a lot of time is being lost. So in the pregnant patient, they should be cared by a combined approach, particularly those who are vulnerable. particularly by the obstetrician and the cardiologist, or obstetrician or the internist. So this type of combined care can give access to the medical care very promptly, and it can save the life of the patient as well as the growing the child in uterus of the patient.
Can I add something?
Yes.
For such a patient, one of the many things that sometimes looked over is the severe hypertension, particularly in late pregnancy. That may be pregnancy-induced hypertension, that may be the preliminary signs of preeclampsia. We forget that. Pulmonary embolism is a very rare cause, and mitral valvular disease occur, and suddenly onset of atrial fibrillation may lead to the sudden onset of shortness of breath that Khalid bhai has very rightly mentioned. And also, this type of patient, if they are neglected by the family, anemia, fluid overload, if they take any painkiller or something like that inadvertently, that may lead to congestion of the lung. All these things should be considered. Again, the history, a little bit of clinical examination can actually ascertain which way we should go.
Actually, Wadud has rightly pointed out, but that duration of pregnancy is only 2 months. So we cannot consider pre-eclampsia here, but this should be essential hypertension.
I was saying the late pregnancy.
Yeah. But if the patient is pregnant before hypertensive before pregnancy, it may lead to hypertensive heart failure as well.
But particularly this type of patient, occult valvular disease are sometimes identified only at this stage after becoming pregnant.
Yes.
As you have paid more importance to that. You are right.
Another question, a diabetic patient, hypertensive patient, history of bypass surgery, presenting with sudden shortness of breath. What are the diagnosis?
Actually, if the patient is doing well after bypass operation, the duration, how the patient is faring after bypass surgery, that is of very utmost importance, and the comorbidities of the patient. Because the patient who are suffering for a long time from ischemic heart disease and diabetes, they are likely to have the renal disease as well, and they are on an anti-platelet drug for a long time, which might have due to the GI bleeding. They might be anemic as well, and many of the bypass patients undergo CABG after an acute attack of ST elevation MI, and from the very beginning their LV function is jeopardized, and which after a revascularization. And what would be the status of his grafts after surgery? If it is 10 years, 15 years down the line, we can expect some restenosis of the grafts as well. So these are the many factors we need to consider. And the diabetic patient, they don't experience the symptoms well, so they are late in seeking medical attention. They are considering the symptoms maybe as some gastrointestinal symptom or something like that. They are wasting time at home. So this the early medical care thing also is very important in this group of patients. But at the end of the day, the LV function after CABG, it is of the best predictor of outcome in this group of patients actually.
Hello, Mohsin.
Sir, unmute.
The difference between the congestive heart failure and left ventricular failure. Simple question, but for the examinee, sometimes examiner asks.
Heart failure, which is associated with congestion in the pulmonary circulation and the systemic circulation, this is called congestive heart failure. But some older examiners, they tend to hear an answer when the heart failure starts from the left side and subsequently affects the right side of the heart. They sometimes tend to hear this, but heart failure we do not always associate with the congestion of the systemic circulation and the pulmonary circulation, because the heart failure with preserved ejection fraction and the mid-range ejection fraction, they don't have a overt clinical finding of congestion in any of the pulmonary circulation or the systemic circulation. So we have to keep this in mind.
Thank you. Dr. Arun Maski, Dr. Arun Maski, do you hear me?
Yeah.
Anything, comment or question?
Yeah.
On the fellows?
Thank you, Khalid bhai. I was your student. As usual, you always present nicely. You are a good teacher. One question we ask in exam is, a lot of patients, because we deal with the cardiac patients, can you just highlight how to differentiate the cardiac and respiratory problem, especially in relation to PND and orthopnea? These are two important aspects. I think if you can just highlight that, it would be great for all the students.
Very relevant question. First we take the orthopnea. Actually, the orthopnea is a patient goes to a lying position. They don't experience anything at the beginning. It's a paroxysmal nocturnal dyspnea. They don't experience anything at the beginning, but when they fall asleep in about half to 1 hour time, they tend to get up with the sudden choking sensation and air hunger. Because the redistribution of the edema fluids, they lead to increased venous return to the heart, as well as the diaphragm is pushed up by the abdominal viscera. Sometimes there is associated ascites as well, and there is also associated pleural in sometimes. All leads to reduced ventilatory capacity, and this patient get instantaneous relief on getting up, and they get more relief when they move to a balcony or to the window. But in case of orthopnea, this is the shortness of breath which prevents a patient from lying flat. Patient cannot lie flat at all if the patient is orthopneic. And PND, the patients are relatively asymptomatic when going to bed, but they develop the symptoms half an hour to 1 hour later. And we have to differentiate the breathlessness of bronchial asthma. It is particularly very predominant in the early hours of the morning, where there is a dip in the FEV1 and peaks expiratory flow rate. So the cardiac symptoms in the early night features, then the respiratory symptoms are the late night features. So we need to differentiate this group of, as a differentiating point, we can take this into consideration.
Can I add something?
Yes, sir.
One of the important things is that PND virtually excludes respiratory disease. PND is very much synonymous with left ventricular failure, left ventricular related failure. So if the patient has orthopnea, that may be respiratory or cardiac cause. But if the patient has PND, it's very, very likely that he has actually a cardiac problem, and that's most likely left ventricular related failure. Maski, do you agree?
Yeah, I agree. That's the important things we always ask in exam. So this is an important point for, thank you.
Dr. Sobi, do you hear me? Yeah.
Yes, sir. Very good presentation. I have one query. Why do the patients of acute pulmonary edema develop that opacity near the hilum? What is the basis for that? Why does not the fluid distribute all over the lung? Is there any disparity in the lymphatic drainage or like that?
Actually, it correlates with the pulmonary capillary pressure. Actually, the pulmonary capillary wedge pressure, if it is less than around 15 millimeter of mercury, you get the upper lobe diversion, and in the next stages, in the around 18 millimeter, if it is, you can get the Curly's line, and if it is around 25 millimeter, you can get the alveolar edema. It is due to the hydrostatic pressure, which and the peripheral. There's some peripheral vasoconstriction in the response to hypoxia. We all know the pulmonary vessels, they constrict with the low oxygen saturation, and this the peripheral vasoconstriction is evident in the pulmonary vasoconstriction evident in the peripheral parts of the lung. It is more, and thereby we can see the features mainly in the central pulmonary arteries. That's why.
Thank you, sir.
Thank you, sir. Chowdhury Mashkat Ahmed, sir, do you hear me, sir?
I can hear you.
Yes, sir. Your comments, sir.
First of all, when I passed my cardiology course, I used to refer my cases in two places. One is to Professor Nazrul Islam sir, and another is Professor Khalid and Dr. Khalid Mohsin, because I always trusted their knowledge and wisdom. So I should not talk anything after his deliberation. But I want to bring attention to some point, if I'm allowed to, about the shortness of breath and the way we learn about shortness of breath. Some important, small, tricky things. Before going to that point, I'd like to interact a little about the paroxysmal nocturnal dyspnea. Definitely, Professor Wadud is a brilliant clinician and brilliant academician. I should not differ from him, but he also likes that someone should differ logical basis. I actually, it is very conventionally, the conventional teachers do ask what is the differentiation, what is the differentiating point between acute left ventricular failure and acute bronchial asthma when it presents as paroxysmal nocturnal dyspnea. Over years, decades, the examiner have been asking this question. Maybe they have got some relevant also, some relevance also. We know cough is the dominant feature in case of bronchial disease, and cough is a relatively later feature. Number two, after sitting or after standing, the patient gets released from the pulmonary edema in 20 minutes, but it does not occur with bronchial disease. Patient with bronchial disease gets released when he cough out the obstructed material. These are the important thing, and the hemoptysis, the color of the hemoptysis and other things. And some senior professor also like to have a description of typical acute shortness of breath due to heart failure and due to bronchial asthma. These are the important point of historical point. But in recent time, I have heard a short video from South Indian professor. It was very interesting because shortness of breath has to be correlate with the cough, and the nature of cough at a times can tell you about what could be the nature of the disease. For example, if it is if it occurs in the alveoli, as in cases of heart failure, there is alveolar edema, and in some case of emphysema when there is damage of the alveolar. Then the nature of cough will be bouts of cough, but small bout of cough. And on the other hand, if you have obstructive disease in the distal bronchial, when you want to clear out the bronchias, then your cough will be violent. These are the things were very interesting that I want to really share. And again, I want to give emphasis on the point that cough is an important point when you're differentiating between heart cause and the bronchial cause. This was my comment about what Dr. Arun asked us. We also like to put shortness of breath in 4 categories, actually. One is acute shortness of breath, and we must know the exhaustive list of causes of acute shortness of breath. So we do not miss any of this cause, because if you miss them, we'll lose the patient. We have to know all the exhaustive causes of shortness of breath, and we have to do all sort of imaging, biochemical, radiological, and other things, clinical, in almost in no time to save those patients. This is the one point that is how we describe shortness of breath. We also say shortness of breath during exertion. That has got host of cause, including deconditioning, pregnancy, overweight, and other simple thing, and some difficult cause. But also we add 2 other categories of shortness of breath, as Professor Wadud has said, orthopnea and the paroxysmal nocturnal dyspnea. And as Professor Wadud wants to say that if it is paroxysmal nocturnal dyspnea, there can not be any other causes, which is very wonderful. You know, if a patient has exertional shortness of breath and also have paroxysmal nocturnal shortness of breath, then the diagnosis is very straightforward, as Professor Wadud is saying. It has to be something in the left heart. Maybe some case of chronic airway disease also we can include. The diagnosis should be very, very straightforward. Same thing occurs with orthopnea. Orthopnea actually occurs in cases of heart failure and in case of obstructive airway disease. Because if you have these two features along with shortness of breath, exertional shortness of breath, which is at a times is difficult to make a diagnosis, then it becomes clear from the history. History is always important. History of cough, history of hemoptysis, history of, if you can divide the shortness of breath in the context of acute, exertional, orthopnea, and nocturnal, then things become relatively easier, what I feel. I also, if I'm allowed to say, as a cardiologist, actually, we have designed a new curriculum. We actually has formulated a new curriculum in the Department of Cardiology, which has been accepted by the university. It is taking some time, but we are giving emphasis on outcome-based curriculum. Of course, Mohsin, I don't know whether he will like it. He wants his student to get an easy way to pass. But we also want our student to be competent enough in their life outcome. They should be able to handle the cases when the patient come to them with shortness of breath. We have actually some difficult cases in our day-to-day practice. Some patient has valvular disease or other heart failure, which cannot be with disproportionate shortness of breath. And again, in some cases, in elderly patient, especially in our age, little obese, this patient do have, many of our colleagues do come to us with shortness of breath, but we do not find any usual causes for shortness of breath. And nowadays, diastolic heart failure is emerging, mild pulmonary hypertension, probably due to sleep apnea and other diseases coming into the spotlight. And there are new modalities of investigation like cardiopulmonary exercise tests, which really resolve some of the unresolved issues in shortness of breath. That has to keep in mind to some extent, because in real life we get some difficult cases of shortness of breath which cannot be resolved with all the investigation that we know, and we apply those. So cardiopulmonary test and some lung test with DLCO2 test, and even in some invasive stress diastolology can be applied for some patients. These are the things actually. What I noted, actually, we run a pulmonary hypertension clinic, Professor Wadud knows it. And by doing that, we also have realized that we will integrate the chronic shortness of breath into pulmonary hypertension clinic, so that the different sort of patient comes to our clinic, and our residents do know how to solve those shortness of breath when they come as shortness of breath. Actually, what is lacking in our education is we consultant at least in BSM, we do not go to the outdoor, and we do not see outdoor patient the way the patient present with the symptom. Actually, since you have started this month with symptom analysis, so I'm taking some time to talking on the symptom. Actually, different sort of symptom, different mixed bag. When we get a mixed bag, how to pick up cardiac cases from that mixed bag, or how we can differentiate them from other. That will be important when we attend the outdoor situation. Actually, the professors in the Western world they do not attend the indoor. 80% cases they do research, 20% cases they attend the outdoor. This concept, actually, we will try to change this gradually, so that shortness of breath and other symptoms that you have started in this month, we can address them with a thorough eyes and other things. Sorry, I have taken a little time.
Thank you, sir. Thank you, sir. Dr. Arif, do you hear me?
Yes, sir.
I think lots of questions in the chat box. Please read the question. Yeah.
So thank you, sir. Khalid sir is one of my favorite teacher always, and sir is always a good lecturer. Sir, one question is related to ticagrelor. So they wanted to know about the mechanism of ticagrelor-induced breathlessness and its management.
Actually, the latest study, they just reported the prevalence. About 13.8% of the patient, they reveal some unexplained shortness of breath. They have not yet elucidated the mechanism, but if the shortness of breath is causing a therapeutic compliance, I think it's better to change the medication, because there are some other medications available to us as well. We can switch over to clopidogrel if it is not resistant, or we can switch over to prasugrel as well. But we have to keep that in mind. So far, the mechanism has not been explained in detail. If anybody knows it, I can just.
Can I add something?
Yes.
The difference of ticagrelor-induced shortness of breath is that the patient will have the shortness of breath during rest. The same patient, while climbing stairs or a little bit of running or walking fast, will not have that shortness of breath. That differentiates it from actual cause due to cardiac problem, cardiac failure or something like that. And some observations have shown, if you give the explanation to the patient, many of the patients can ignore that symptom, that feeling of choking, a little bit of choking during rest time. They can ignore that if they know that this is not going to harm me, this is going to irritate me. But sometimes we do have to change. Another point, not related to ticagrelor, as Professor Meshkat sir was saying about the nature of cough, I always teach my patient, listen to the cough. By listening to the cough, you can actually determine whether it's from the throat or cough is actually, I call it bheja cough. Meshkat bhai has shown that example. Actually, if you listen to the nature of the cough, you can actually determine, and you cannot just describe it. You have to listen to it and listen. Give some practice to it. See a lot of patients with cough, listen to it, find out the actual cause, then you will have an idea. And you can actually say, this cough is due to cardiac cause, this is due to lung cause, this is due to throat cause, something like that. Thank you.
And
so
also, the sputum as well. When the patient expels something, we need to have a look at it. It can give a lot of information as well.
What they say of ticagrelor is they increases the adenosine level,
Right.
Yeah.
and because there's a decreased clearance of adenosine, they say it could be one of the postulatory mechanism of dyspnea with ticagrelor, which is not established.
Yes, sir. Rightly said. Adenosine concentration increase in the blood circulation. Thank you, sir. Arif, next question.
So there is another question is related to aspirin. So what to do? Most of the patient getting aspirin in case of bronchial asthma, and what is about cardioselective beta blocker in case of breathlessness or asthma? Because most of our patients getting aspirin and cardioselective beta blockers. You experience that?
There is a specific subset of bronchial asthma patient who experience shortness of breath on aspirin. There are a very small percentage actually. So I think aspirin is a very important drug for all subsets of cardiac patient, particularly the ischemic heart disease patient and the cerebrovascular disease patient. So I think it is not wise to withdraw aspirin on the plea of just a minor shortness of breath. So we need to evaluate the patient nicely, and we can do some testing, the patch test or something like that. This sort of the antigenic we can check it. So if there is no documented evidence is found about the hypersensitivity of aspirin, it is better to continue. And the beta blockers, I think the present day selective beta blockers which we use, like bisoprolol and metoprolol, they are relatively safe, but some patients, particularly when they have a respiratory infection or something like that, or a pulmonary edema, they get some shortness of breath, but it is not directly related to the beta blocker. But when we are using the non-selective beta blockers like carvedilol, we must be very careful. It can precipitate bronchospasm because they are blocking on the both beta 1 and beta 2 receptors. But if we can identify the beta blockers which can only selectively block beta receptor in the myocardium, then it is relatively safe. But we have to be cautious. And if we consider that the patient is having symptom, we can change those drugs. We have a lot of alternatives in the form of the calcium channel blockers like diltiazem. Then we can have the ivabradine as well. So we have got a lot of options in our hand nowadays.
Khalid, can I add something?
Sure, sir.
Yes, sir.
Actually, only the subset of asthma patients who have nasal polyp, they are prone to develop aspirin allergy. So the very simple way of clarifying things, ask the patient if he has plenty of sneezing. If the patient has sneezing much more, that patient is going to respond badly to the asthma. And that around 12 to 15% of the total asthmatic patient, not more. So it's very wrong that we sometimes people withhold aspirin. Most of the time we don't have to. I have seen patients in whom aspirin induces severe asthmatic attack. They are very much allergic. In those patients, you cannot use it. The second is beta blocker, as Khalid Bhai said. We have to be careful about carvedilol. And we can use bisoprolol and nebivolol as well. These two, without much problem. Nebivolol can be used in COPD patient as well, without much bronchospasm. And alternative Khalid Bhai has already.
Thank you.
Sir, what about celiprolol, sir? Celiprolol, sir. Do you have experience of celiprolol?
Celiprolol is also can be used safely in asthma, but unfortunately it is not available in our market.
Right.
It used to be available when we were working as we were students of MD third part in NICVD. At that time, I have seen our teachers using celiprolol. Jalal sir or Sufia madam can give us more idea about this historical drug, historical beta blocker, I think.
Right. So that is one of the important
question.
Sir. Sir.
Why beta blocker is contained in severe heart failure?
Actually, beta blocker is not indicated, but in the NYHA patient is in NYHA class 4, you try to avoid beta blocker. But in other classes of the shortness of breath, I think it is beneficial, particularly in the setting of ischemic heart disease. It has got, it can improve the diastolic compliance. It has got a very good antiarrhythmic effect if we choose the beta blocker efficiently. I think there is no reason to withhold beta blockers in NYHA class 1, class 2, and class 3 patients. But in class 4, we have to exercise our caution.
Can I add something?
Yes, yes.
Sure, sir.
A beta blocker is not contraindicated in severe heart failure unless the patient have very much congestion. Because at the starting of the beta blocker, the patient can have aggravation of heart failure. If you want to start a beta blocker in this type of patient, you have to start it in hospital and at a very low dose. Norwegian study have shown even at a systolic pressure of 80 millimeter of mercury, stable patient, NYC 2, but blood pressure is very low, ejection fraction is very low. They have started carvedilol at very low dose. Even then, patient remains steady. And gradually, interestingly, as the heart pumping improves, heart hemodynamics improves, the blood pressure actually improves. So we have to decongest the patient, start always ACE inhibitor earlier on, stabilize, dry up the patient, then start beta blocker, and you increase the dose of ACE inhibitor in days to weeks, but you increase the dose of beta blocker in weeks to months, much more slowly. That's the idea.
Can I make some? Actually, yes. When beta blocker was first introduced in heart failure, atenolol was a drug, and as Wadud has rightly said, it started in the Scandinavian countries, in which time several professors were asked in different countries of Europe to visit to know whether this patient will require beta blocker or not. The judgment was so crucial. I still think it is a crucial judgment about giving beta blocker in some patients, because the evidence says that in 15% cases there can be deterioration after giving beta blocker. That is where actually the concern is. So the clinician beforehand should be able to forecast whether there is any chance that this patient will deteriorate. There are some echocardiographic and some biochemical features which can also help us in making the decision. That is the point I actually wanted to mention. I personally continue the beta blocker when a patient with heart failure do have it, but a little shaky. Since Professor Wadud have said that it is not that problem, he has vast experience. I believe we will not be afraid of giving beta blocker. But we also should keep in mind that some patient may deteriorate with beta blocker.
Thank you, sir. But we should give the beta blocker at low dose in every cases because it will save the life.
Yes,
sir.
absolutely.
Most important thing, sir. But it should be low dose.
In hospital. In hospital, you have to start it in some patients. And 15% patient, they can deteriorate.
Yes, sir. But it should be lung should be die.
In low dose and titrate very slowly, not before 2 weeks. Right.
And firstly about dryness of the lung should be dry, increasing the dose of beta blocker. Thank you, sir. Arif, your comments. Arif,
regarding diastolic dysfunction, so diastolic dysfunction, some of cases we found they present with breathlessness, and echo showed diastolic dysfunction. In that case, focusing diastolic dysfunction, how we can manage these cases?
Actually, in diastolic dysfunction, there is the compliance of the ventricles. It is affected by either fibrosis or any other pathologic process like hypertrophy. So in these cases, we need to optimize the LV filling. And if this patient goes into atrial fibrillation or they goes into tachycardia, if there is the absence of atrial contribution or there is a impaired diastolic filling, this patient becomes symptomatic. So we need to optimize these two things very much. And this sort of patients, they should not be subjected to hypovolemia, because if they end up in hypovolemia, their cardiac output tends to decrease. So we need to optimize this group of things. And if this group of patient goes into atrial fibrillation or a tachycardia, they should be brought to sinus rhythm as soon as possible. So with this group of things we need to check and optimize the diastolic filling. That is the mainstay of treatment.
Thank you, sir.
Okay. Arif.
Sir, should we proceed, sir?
Next question, yeah.
There are lots of questions related to young female with dyspnea, sir. And several questions. So the summary is that what is the differential diagnosis of young females presented with breathlessness?
Young female.
I think exam question.
Married or unmarried, spouse staying at home or abroad.
Covering also.
Very
lots of questions related to this issue.
The exam question, sir. Sometimes giving the 25 marks question, so they want to know, sir.
Actually, you have
which one is first one, second one, 5 DD.
Specify the background of the patient. That is very important. The background should be specified. As Professor Wadud has said, in a majority of our country, the female patients suffer from anemia. This is, in my opinion, I think this is one of the most important factors. We need to exclude the diagnose the anemia, identify the type of anemia, and correct the anemia. That is very important, even if the patient is suffering from a cardiac illness or not. And regarding the occult rheumatic heart disease, these are also because the female patients have got less access to the healthcare because of the financial and social reasons, and that's why they present very late when the shortness of breath has occurred. This one thing, many of the patients, they suffer from the acute kidney injury or chronic kidney disease, which also lead to the congestion of the lungs as well as the body. And we should be considered, in our experience, we see, I think Jalal sir, Sufia madam can give us more input. Dilated cardiomyopathy is also more common in the female population of our country. So and definitely the pregnancy also poses an additional load of the heart of the female patient, particularly if they are anemic And we should not forget about the peripartum cardiomyopathy and pulmonary embolism. So all the factors should be taken into consideration. I think Sophia Madam can give us some more experience her experience regarding the female patients, right? Madam, please.
Yeah. Assalamu alaikum. Good evening to everybody. Special thanks to Professor Wadud and Mohsin. And as usual, Khalid has presented excellent. It goes without saying, excellent presentation. I just want to summarize what you have already spoken, but for the fellows, you see, at the end of this is very common symptom. Breathlessness is very common symptom. There's no doubt about it, but you have to really go to history. Take a good history. Then you we have to have the patience. These days we don't have the patience, but good old teaching, and now also and in future will be also, you have to take the history very meticulously. If you take the history, that will guide you and lead you to the way to go. And then you can, the rest is important. 50% job is done already because you have taken a history like breathlessness, when it occurs, how it occurs, and whether it's a new, is there any weakness, and then PND, is it, what is the PND, and you have to really go through it, and then you can differentiate the underlying causes. So 50% of the thing, if you have the patience and have the good history, then it will lead you to which way to go. And after that, Khalid, Mohsin has you see, I apologize to all of you. I forget to tell you professors and all these, because you were my students before, and with that affection, I still call your first name. I'm saying that if you have a patient and then if they complain, then make sure that you have taken the history, and that will guide you where to go. After that, make a habit of taking the history. After history, think about which system is involved. So either you start from your head to the big toe, or start from the big toe to your head. How? Then you can know, is it neurological, psychological? Is it something in the bone and muscle? Is it something in the lungs? Is it something in the heart? Is it something in the hepatorenal region, or something else? So if you go like that, make a habit of it, and then you will find that it is much easier for you to reach the diagnosis. Once you go there, then the investigation is to help you to treat the patient and to support the patient. Now coming back to females, I know, because most of the time they think it is supratentorial problem. It's not that. Especially if a young girl comes very pretty and complaining very much special art, when she's saying, so you might think, well, yeah, must be supratentorial, but it's not that. Most of the time, absolutely rightly pointed out by discussion, is that most common is anemia. No doubt about it. We should check. Nowadays, they have a sort of fear of they will be more fatty if they take food. So they take wrong food to diet, and all these things are there. So the history will again lead you where to go. And these young ones, once you have seen the underlying causes, after exclusion, you can say that this is something to do with the supratentorial region, meaning psychological or other things. So for the easiest way, and as a physician, we shouldn't think, because one has come to you for your help. So try to help, try to take the history so that you can exclude one by one and then reach the goal and treat the patient. That way you can achieve it. I have to leave if you don't mind, and I'm really congratulating all of you for having a real good discussion. And it's one of the most common symptoms and one of the most difficult thing to treat. But if you know what is the underlying thing, then you can always treat it. Thank you again. Thank you so much. Okay.
Thank you, madam.
Walaikum assalam. Khalid Mohsin, sir, do you attention on the primary pulmonary hypertension in case of young female?
Yes, actually, primary pulmonary hypertension also comes, but it is also a diagnosis of exclusion actually. So we need to exclude the common causes first, and if we cannot find anything in the common workup, I think we will definitely consider this. And it is also a female predominant disease actually, no doubt about it. But I would like to hear some opinion about from Jalal sir. Actually, he has also got a wealth of experience in dealing patients with shortness of.
Jalal sir. Yes. Sir, everything okay, sir. Yes, sir. Sir, everything is okay, sir. Please, sir. Sir, everything is fine, sir.
Hello.
You can talk. We are hearing you,
Yes.
sir.
May I talk something?
Yes, sir.
May I speak something now?
Yes, sir. Now, sir.
Today I'm very happy and I feel proud that Dr. Khalid Mohsin was working with me for a long time in NICBD. And I am very happy to hear his deliberation today. And the breathlessness, the little breathlessness and fatigue is very simple track. Very simple talk. It seems that it is nothing, very simple encountered, sometimes it is not encountered. But so many things remains behind this simple breathlessness and fatigue. Today, Professor Khalid Mohsin had discussed so many things behind this simple thing. So he has mentioned, as well as Professor Sufia Rahman also ended, that history is very much important. In our time, history was so important when there was very little things for further investigation like echocardiography, MRI, CT scan, which are done nowadays very frequently. So history and initial physical examination gives the way how to diagnose this patient properly with minimum investigation and manage the patient accordingly. So I will not talk so much things that the Professor Khalid Mohsin, Professor Mr. Chowdhury, as well as other Professor Wadud and other panelists also discussed so many things today about this topic. So I don't like to enlarge so many things. You have also mentioned many things today. Thank you very much. And thanks to Dr. Khalid Mohsin, Professor Wadud Chowdhury, and Dr. Mohsin. Thank you very much once again.
Thank you, sir. Khalid Mohsin, sir. The last question. What is the difference between sleep apnea and PND? Number one. One fellow asked. And another question is, how many times experience a single patient in a one night PND?
Okay, thank you.
How many times he experienced PND in a single night?
Yeah, I would like to answer the first question in the beginning. The obstructive sleep apnea. Obstructive sleep apnea, actually, the patients themselves they don't experience not many symptoms. Their spouses or the patients who share the room with the patient, they actually initially they are the main witness and they experience the symptom. And in this case, there is the sleep apnea is accompanied by the apneic attacks, and the patient wakes up. There is before the apnea, there is some deepening of the respiratory effort due to there is the accumulation of the carbon dioxide in the system, and which depresses the central chemoreceptors. And at one point, the chemoreceptors become insensitive due to the high level of carbon dioxide, and that point the patient wakes up. And there are some additional symptoms like the daytime somnolence, and like there is the associations like the hypertension. There may be some associated pulmonary hypertension. There may be if they drive, they encounter a lot of road accidents, and sometimes they develop intractable pulmonary hypertension as well if they remain untreated. And thereby, if we examine them, we can see that sometimes there is significant hypoxia of the patient, as well as some of the patients, they have hypercapnia, the type 2 respiratory failure, and they should be subjected to a polysomnography and the CPAP. Sometimes in the hospital, if we have a CPAP, we can put the patient on CPAP as a therapeutic trial as well. And in case of PND, the symptoms occur earlier part of the sleep, particularly going to bed half an hour, 1 hour, and there can be recurrent attacks. When the patient feels better, he goes to sleep, and again in the early part of the morning, there may be a recurrence of attack as well. But many of the patients, they find some way to get a bit of relief from PND. With the help of the physicians as well as by themselves, they tend to prop up at night. They tend to sleep in a well-ventilated rooms, and something they find some respite from themselves or with the help of the physician. But in cases of obstructive sleep apnea, there is not such respite as well. And in case of obstructive sleep apnea, many of the patients are obese compared to the patients with heart failure. There are some, in case of obstructive sleep apnea, there are some ENT problems as well, like they have a nasal polyp or deviated nasal septum. They can confuse with obstructive sleep apnea. So before we diagnose a patient with obstructive sleep apnea, it is better to send a patient to the ENT specialist for evaluation of these obstructive features of the upper airways as well.
Thank you, sir. What is the bedopnea and perypnea? Sir, unmute, sir.
Since the shortness of breath is aggravated by bending formers. And another thing, another terminology?
Yeah, platypnea.
Platypnea. It is the standing. It is in the standing position. There is more shortness of breath. Yeah.
Thank you, sir. I think lots of questions. Thank you, sir. I think your lecture is enriched our IPDI archive. I heard, sir, not only junior faculty, participants, senior also called me. They hear the lecture again and again at the late night or midnight without hearing the I think, song. The গান্না শুনে তার IPDI lecture শুনি। এটা শুনে আমাদের খুব ভালো লাগলো স্যার যে তারা সিনিয়ররাও এই যেমন মুশকিল স্যারের lecture বা আপনাদের lecture শুনছে সবাই রাতে বেলায়। ফলে এটা আমাদের IPDI really we are grateful to you, sir, for presentation for uncommon subject. Thank you, sir. Thank you, everybody. Wadud, sir, do you hear me, sir?
Wadud,
sir, I think
left for consultation, patient teleconsultation.
ও আচ্ছা স্যার, আপনি স্যার বোধহয় সাকিব করছি স্যার, ডিসকানেক্ট হয়ে গেছে, আসছে আবার।
আমি যেটা মনে হয় আগে দিলে হতো আসলে প্রথম দিকে যেটা নিয়েছেন সিনকোপ, চেস্ট পেন, প্যালপিটেশন এন্ড শর্টনেস অফ ব্রেথ। হ্যাঁ, এটা আমাদের শিডিউল হয়ে গেছে। হ্যাঁ, আমার মনে হয় যে একটু প্রথম দিকে
না, এটা স্যার একটা ভালো হলো স্যার, সবাই হলো স্যার, আগেগুলো রিচার্জ হলো স্যার, এটাও খারাপ না স্যার, যে আগের গুলোর সম্বন্ধে ধারণা হতে এটা সহজে বুঝতে পারবে স্যার জুনিয়ররা, দে ক্যান মেমোরাইজ এভরিথিং। I think so Wadud sir, before your conclusion, I just give some announcement, then you say conclude the session.
Thank you, Khalid. Mohsin here.
Just announcement. Our next class, evaluation of palpitation, will be taken by Professor Dr. Adhali. He also one of our favorite teacher. And then Professor N.M. Mohsin sir, evaluation of chest pain. On 20th September, Atharli sir, and 24th September, Thursday, 8 p.m. Professor Mohsin. And then when I announced in our OSPE evaluation and examination, we changed our date on 1st October, Thursday, and another is on 15th October for discussion. For the OSPE examination, all the participants should be registration form to attend the OSPE exam. Just click the link we already posted in the Facebook and fill up the name, his institution and degree, so he can join in the examination. Thank you for your announcement. Always, sir.
Thank you, Mohsin. That was very important. Today's lecture is Khalid himself was saying that it's very important that the symptomology of cardiovascular medicine depends on actually 4 or more things, not more than that. But to discuss those things, we have to know a lot more. And we have to understand a lot more. Today's lecture has shown that. And Meshkat Bhai has given a very good input regarding the importance of other symptoms, including cough, and how much information you can get actually by linking one thing to the other. As a whole, we have really enjoyed today's lecture, and the input from our senior teachers actually inspired us. I have been disconnected for a few minutes, but I think every minute that we spend here is actually worthwhile. Thank you, Incepta, for helping us for all these months. And Mohsin and your team, including Shajol, kudos to you. You have done a tremendous thing. Thank you, everybody.
Thank you, sir. Thank you. On 20th September, on Sunday at 3:30 p.m. We have another announcement. Next month, IPDI Thursday night for IPDI. All the class will be all held on Thursday night. So I think after chamber, we can sit together in the long time, we can get together and discuss more times. Thank you, sir. Thank you, Mishka sir. Thank you, Khalid Mohsin sir. Thank you, everybody. Assalamu alaikum.
Assalamu alaikum.